Good morning. Thank you so much for inviting me. I love coming to Focal, and it's amazing to see how it has grown, truly. We were just talking about it this morning. So apologize, this is going to be very basics of MRI, so I hope I don't bore anyone, but good refresher. And you can imagine in the space of focal, MRI holds a very high space. So let's just start out with the case. A 62-year-old man who came for a second opinion to Cincinnati. And this is his MRI that he brought with him. And right away, this is not prostate MRI. This is still happening, unfortunately. Prostate MRI is really a small field of view imaging of the pelvis, and specifically to look at the prostate gland. And then the term also comes up, multiparametric. What is that? Just a couple of different sequences that we use to evaluate the entire gland. There's T2 weighted sequences for anatomy. For biology, it's both the diffusion and the vascularity that we look at, tumor angiogenesis. So when we look at the zonal anatomy, which we can really see nicely on a nicely performed prostate MRI, you can see the peripheral zone is bright, and the transition zone is dark centrally. And I will just kind of go over the anatomy a little bit, anterior fibromuscular stroma there. And we can nicely evaluate on this specific image, you see the bladder on the very top, ejaculatory ducts, et cetera. And if there's hemorrhage there, you can see as well. So T2 is specifically for anatomy, and then T1 we use for evaluating the other parts of the gland, which I will go over. So here we see the peripheral zone. You see the bladder superiorly. I'm going to repeat this a couple of times just to kind of, as a refresher. Prostatic urethra, and then we see the purple is the fibromuscular stroma. Transition zone has a lot of stromal BPH, glandular BPH, and so that can look a little heterogeneous. And so when we look at the peripheral zone, it's in an example like this, it's primarily glandular, and it's very bright and wraps around anteriorly. And transition zone, though, is what gives us still problems on MRI. And as is in this case, normally it's smaller in size, and as BPH occurs, you can still delineate the two lobules of the transition zone, et cetera. But as you can imagine, when there's a lot of BPH, the bright stuff, there's glandular BPH, the dark stuff is stromal BPH, and then you really don't see much of the peripheral zone. It's just all attenuated. And this has also been dubbed the well-defined, the organized chaos. So it's hard to tell where the lobules are, so you really have to go superior to inferior all the way to really evaluate the transition zone carefully. And peripheral zone is hard to see in a large gland like this. Central zone, that's superiorly, it's dark, it's cone-shaped structure, and that inverts inferiorly, and it's dark on T2. So, but the nice part is it's symmetric. Now, BPH can change that. BPH can make that asymmetric as well, and so that's where some of the problems arise in evaluating this. But it's going to be dark, and because it has more stroma tissue than glandular tissue. And then anteriorly, we have the anterior fibromuscular stroma, which is going to be dark, both on T1 and on T2 weighted images. So if you just evaluate the zonal anatomy on a coronal image, you can again see the central zone on the very top and the pink. Then you have the transition zone, the green, and then you have seminal vesicles on the top. And I'll go over some of the stuff on seminal vesicles at the end. And then you can nicely see the prostatic urethra. So for zonal anatomy, we primarily look on T2 weighted sequences, right? So T1, as you can see, why we can't really evaluate the prostate at all. It's just all dark T1 signals. What do we do that for? We do a large field of view T1 weighted sequence to evaluate the bone marrow, which is best seen on T1. We also do to look if there's any underlying hemorrhage, or do local staging as well. So those are the reasons for T1. But let's look at this example. Here you have T2 and T1, and the peripheral zone looks very similar to the T2. Interesting, huh? That's all because of hemorrhage. So we really want to wait about 6 to 10 weeks, if there's any chances of having hemorrhage to that extent, because that'll distort the exam. So what does cancer look like on T2 weighted sequences? It's going to be dark, large mass like this. Easy to tell here. And it's the transition zone really that gives us a lot of problems. And that's because typically the transition zone cancer will be divided into typical lenticular or water drop shaped, or it can be globular where it can mimic BPH. So for example, but it's going to be homogeneous. The key is that it's going to be homogeneous and with ill-defined margins, and once you've seen enough, it's not that difficult, but transition zone is still where we are not the best on MR. And in this case, the first image, you see the globular, the ill-defined area, and then the second, the next two are, I can't really have my arrows, oh, here they are, sorry. Here's the homogeneous ill-defined area here, and then you've got more water, globular shape, and then more lenticular area that the typical transition zone cancer will look like. How about here? You've got this glandular area, and then this smudge, the erased charcoal sign. Again here, large anterior mass. And those are the typical transition zone type tumors. So let's recap anatomy on T2. So you have a discrete nodule here on axial T2 and on the coronal T2 weighted sequence. This is a mass. What about this ill-defined area, this stuff? This is the typical prostatitis. Then you have, here's transition zone centrally, and you see heterogeneous areas, bright stuff, dark stuff, bright stuff, and this is all heterogeneity from the transition zone BPH. And then you have cancer. This is a large mass, and the border between the transition and the peripheral zone is ill-defined here. You can't even tell, and this entire thing is a big mass. And once they get radiation, the entire gland becomes dark, even on T2. So it's really hard to evaluate anything after radiation. So you really need contrast, or diffusion helps as well, but contrast is where we use that. All right, so what about the periprostatic anatomy neurovascular bundles? We see them usually in the posterior lateral component of the gland, and it can be quite variable. And all we see are these black dots, really. Those are the neurovascular bundles on MR, and they have varied shape as well. There are several mimics of malignancy on T2. So T2 is great, right? I was showing you the mass, but a lot of things can look like cancer on T2. For instance, that's a hematoma. So anatomy is great, but we really need some other sequences to better evaluate. And diffusion is really, really the workhorse of prostate imaging. And what it does is it specifically evaluates, so any high intensity in an image of voxel, it's measuring the diffusion of water in the tissue. So if the cells are widely apart, there's more movement of water as opposed to when they're tightly packed. And then apparent diffusion coefficient, a velocity map is derived from the diffusion, and we're looking for restricted diffusion, such as in cancer, there'll be tightly packed cells, and you'll get on ADC a dark area, and that's the diffusion restriction. So for example, here's a peripheral zone mass. It's bright on diffusion weight sequence, which is, we use different gradients. We need at least B value of 1400 or above. And it's dark on ADC. And this is a large transition zone mass, bright on diffusion, dark on ADC. So we're looking for black and white on diffusion. We're looking for discrete mass on T2. And then we can look at some contrast. Okay, what is the limitation of diffusion? I want to share this with you. This is a very old exam. Just wanted to show you that this is a T2. This is a T1 weighted image. They had T1 and T2, and this is bright signal. You can see this is all hemorrhage. And on T2, what it looks like is this vague low T2 signal right here. This was a man who came, for his prostate MR. He had very high PSA. Diffusion was all distorted, nothing on there. Because post-biopsy hemorrhage can really distort that. So now bring him back in February. So he came in originally in December, came back in February, and you can see a large area of restriction you couldn't even see initially. So hemorrhage, if there's hemorrhage, just be leery that we could be missing cancer underlying. What about contrast? It's tumor angiogenesis that we're evaluating, but the problem is prostatitis and BPH, et cetera, overlap with that. This is a big question, which, do we need 3T or not? Obviously, 3T is preferred, but the 1.5 Tesla is still used for a lot of conditional devices, and the newer 1.5s are beautiful with higher gradients, so I think it's really the signal to noise. If you can get that, you can use 1.5. Guidelines, so the guidelines have started a long time ago, right, in 2012, but then the most recent one, The Pi-rads 2.1 gives you nice images, examples. So it's on the ACR website. So just going to quickly kind of skim over that here because of timing. So here's an example. Where's the lesion here, right? So there are two different patients. Axial T2 weighted images. The lesion here is in the peripheral zone. And the lesion here, in the peripheral zone, diffusion dominates, because when we're looking at Pi-rads, we're going to see which sequence is going to dominate, and I'll go over how we use that. And in T2 weighted sequence, it will dominate in the transition zone. So he's a transition zone cancer. The T2 will be dominating here as opposed to diffusion in the peripheral zone. Same cancer, it's just how we're going to describe it on Pi-rads. And again, each lesion is assigned a specific Pi-rads score, and it's 1 to 5 scale, 1 being very low and 5 being very high. But basically, 1 and 2 are normal, 3 is not sure, 4 and 5 is cancer. 4 is cancer and 5 is cancer because 4 is 1.5 centimeters or above, and then 5 is either it could be small, 1.5, or it's extraprostatic, then it becomes a 5. So basically think of 4 and 5 as cancer, 1 and 2 normal. But remember, this is only for detection of clinically significant tumor, not for staging, not for post-treatment evaluation, because that's something that I feel there's still confusion about. So so the scoring in the peripheral zone lesions is different for peripheral zone as opposed to transition zone. And this is just an example from the ACR website. You can see this is all listed on there. For example, Pi-rads 1 is going to be homogeneous, bright signal in the peripheral zone. If you're going to have some areas of little band-like areas, becomes 2. This is all for peripheral zone, by the way. And then if it's heterogeneous, it's a 3. Now, for 4, you need a discrete nodule that's less than 1.5 centimeters, right? If it's greater than 1.5 centimeters, or if there's obvious extraprostatic, it becomes a Pi-rads 5 in the peripheral zone. So this is all present on the ACR website with examples, et cetera. So please do go and evaluate that. There are also listings for what the T2 weighted sequence looks like in the transition zone, and again for diffusion for both peripheral zone, transition zone. We won't go over this, but let's just go over an example. So here's a man who came for active surveillance. He had 5% in a random prostate biopsy. He had 5% tumor on the right base. So he got an MRI. When you look at the base, really don't see anything on the T2. And again, on the ADC, I'm just showing you 2 images, but just have to believe me, there was nothing that we could find on the base. But when you looked at the apex, there was slight asymmetry. You see slightly more tissue, low T2 signal here, kind of heterogeneous, as opposed to the other side. And then ADC, there was some dark area here, so there was some restriction. So let's look at how we would look at this on using Pi-rads. So for instance, when we look at a T2 apex like this, it's kind of heterogeneous. There's no discrete nodule, right? So this is a 3 out of 5, meaning that it's not 1 and 2. It's not normal. 4 and 5 is not discrete nodule, not 1.5. So this is 3 out of 5. And then there's focal restrictions, black and white, right? This is focally restricting. And so that's 4 out of 5 because it's not greater than 1.5 centimeters. And this had focal enhancement that extended inferiorly. So there was distal apical extraprostatic extension in this case. So this man obviously is unsuitable for active surveillance, even though there was a vague lesion in the right apex. The contrast really here helped a lot because that showed how much the enhancement was extending inferiorly. What about this case? This is an interesting example. Here's an axial T2 weighted sequence. Again, remember, glandular tissue in the peripheral zone is supposed to be bright, but not every MR, shows that as well. So it's kind of hard to tell, but there's slight low T2 signal in kind of a linear fashion, and you can see a little bit of ADC restriction. These are some of the areas that are often missed on MR, unfortunately, and this is a typical subcapsular lesion that was seen better on coronal images. So we always do multiplanar for that reason. We don't want to just do axial T2s. We do coronal or sagittal. You can at least do one of the other. And in this case, it was nicely seen on the coronal image. And this is the value of multiplanar imaging as part of the multiparametric prostate MRI. All right. and this was a Gleason 7 tumor. We can also stage, so when we're doing MRI, although we're not using Pi-rads, we can nicely stage the tumors at the time, and here's an example of a tumor that was in the apex anteriorly that extended further down, and you can nicely see, especially tumors that are going below the, involving the urethral sphincter or involving the levator ani muscles, et cetera. So that staging can be performed nicely. Patient prep, there's quite a lot of controversy about this, but certainly you don't want hemorrhage. You want to wait at least 6 to 10 weeks if there's a possibility of hemorrhage. Avoid sexual activity for 48 hours. I'll show you some examples why, to better evaluate the seminal vesicles, light meal, et cetera, fleet enema prior to exam. And in terms of staging, obviously, gross extraprostatic extension, as in this case where mass is extending out, is thankfully, we don't see that often. But we really rely more on the secondary signs. And so what are the secondary signs for extraprostatic? So really, capsular bulge is one of them. A mass that's either the capsule or the area of the margin of the prostate is irregular, or if there's a broad capsular contact of more than 1 to 1.5 centimeters. And so that is something worrisome for extraprostatic. And there's variability, as you know, even within pathologists as to when they will call. There's grading that pathology has for EPE. And in this case, you can see when there's large volume tumor that's extending around the margin, that's worrisome if it's greater than 1.5 centimeters. And we can also see nicely the extraprostatic findings. So the positive surgical margins, where are they? Mostly, they're going to be in the prostate apex. That's often also the areas that are missed on MRI, by the way. The posterior peripheral zone, this area should not, this is nicely seen on MRI, so this is not often missed. But again, the base of the prostate, again, is one area that can be missed. This is an example of a large mass posteriorly. So this is a 5 out of 5 Pi-rads. There was posterior lateral extraprostatic extension. What about this? This is often that people don't report. So there's a large mass. People are just excited to see the mass because it's dark and it's enhancing, et cetera. But there was extraprostatic, anterior extraprostatic extension in this case. Little bit of spatial distribution of transition zone cancer. If it's unilateral, it can be anterior involving the fibromuscular stroma, or again, the peripheral zone kind of going anteriorly and going to the anterior fibromuscular stroma here. So let's look at this. This is the erased charcoal sign, and this is the BPH. So you can see the ADC restriction and this ill-defined erased charcoal homogeneous low signal mass in the transition zone. It's unilateral transition zone cancer, right? We can also do some of the extraprostatic findings, such as the seminal vesicles. When a tumor goes up superiorly in this case, you can see this is just low T2 signal. But most often what we see in the seminal vesicles is going to be hemorrhage. And this is a T1 weighted sequence. Again, you can see hemorrhage nicely within the seminal vesicles. And this is just a utricle cyst. So this is the reason I was saying one of the prep is to avoid ejaculation for 48 to 72 hours, because you can get nicely distended seminal vesicles. So for staging, that makes it nicer. We can also see lymph nodes, bony areas that are better seen on MRI, et cetera. And then this was not seen on typical nuclear medicine scan that you can see. But of course, now with PSMA PET, that's a totally different thing. Now, but what about bladder? We can also see bladder lesions. So we see a lot of extraprostatic rectal, bladder, et cetera. But do we miss cancer? Yes. So even with all the acquisition optimal, you can miss up to 11%. And it's this mucinous type of tumor, or if they have cribiform pattern, we can miss those. So I just want to go over this quickly. We may miss the MR invisible lesion, right, for these reasons. But what we may also miss on MRI is because of quality. This is a bigger problem. So when there's patient prep issues or MR acquisition issues, it can really, really derail the whole exam. Reader quality and interpretation, and then really these atypical MR findings, these subcapsular tumors that one I showed you earlier, where it's so thin and against the margin of the gland that it can be missed, or the real low apical tumors, or the anterior tumors that are, because of the BPH, are smudged anteriorly and can't really actually see them. So all of these reasons, DCE helps. And when we do the unknown panel case, I'll show you examples of how that's helpful. So thank you.